Welcome to the Asher Acupuncture Podcast, sharing clinical tips and techniques to help you help more patients. Here's your host, Eric Shanky.
I'm so happy today to have Dr. Lucy Whyte Ferguson on. Dr. Ferguson is an expert on trigger points and has studied with some of the greatest in the field, including Janet Travell and Robert Gerwin. She is literally the author of the book, or at least the chapter on trigger points and shoulder pain. And I'm here today to pick her brain about treating the shoulder and what are the most common problems she sees with the shoulder. Dr. Ferguson, thank you so much for being on the show.
Good morning. Thank you for inviting me.
Dr. Ferguson, my audience is mainly acupuncturists, and they may not have a real understanding of what a trigger point is. Could you briefly describe the concept of a trigger point?
Sure. Well, when a muscle is injured, it can just go back to normal afterwards, but it is not uncommon for there to be remaining problems after either repetitive strain injury or a traumatic injury. And the muscle can have taut bands within the muscle, so the whole muscle is not in spasm, but there are taut bands. And within those taut bands, there can be an exquisitely tender nodule. Now, that nodule is referred to as a trigger point. They can cause pain locally, but they can also cause pain that is referred to other locations. So in the context of the shoulder, for example, anterior shoulder pain, there are at least 10 different muscles that can refer pain into the anterior shoulder, even if they are not actually located there. And then basically, one of the things that can be done is to palpate that knot but with a cross fiber pressure. And when you put pressure on it, it will reproduce the pain pattern often if it is responsible for that pain pattern. Now, we have composite pain that's caused by several different muscles or a combination of muscles and joint pain and etc. But essentially, you can diagnose which muscles are primarily responsible for the patient's pain by using manual palpation techniques.
And so what is the most common type of shoulder problem that you see clinically?
Well, I'm known for my work with frozen shoulders. Mm-hmm. So basically, they're challenging to work with, and I've developed a different protocol from what I was trained in. I mean, basically, most physical therapists and chiropractors and medical doctors are still taught that there is either a process of adhesions or thickening of the joint capsule, and that you just have to sort of tear into that. And it's been my experience that that's not the most productive way to treat a frozen shoulder. And so I've developed an alternative approach that seems to be quite effective and gets people well sooner.
And when a patient comes in and you suspect frozen shoulder, is it mainly through assessing range of motion that you would determine, yes, this truly is frozen shoulder?
Yes. I mean, basically, patients may think they have a frozen shoulder, but essentially taking them through range of motion, and it's defined as a condition where at least 50% of the range of motion is affected. And so that's what we work with regularly. And the body is organized in a different way around the shoulder when that's taking place.
And clinically, I've seen frozen shoulder used as a kind of a catch-all phrase where if the patient has pain and limited range of motion and they do an MRI study or an X-ray study and don't really find much, that's when they'll tag that label on there.
Well, I am also, for example, sent patients by my local orthopedic surgeon because he knows that they've torn up the shoulder in certain ways and that it will need to be surgically repaired. But if the patient doesn't have some reasonable range of motion. That the last patient that was referred to me only had 45 degrees of flexion, couldn't even raise his arm to 90 degrees. So to go into a surgical procedure with the range of motion so limited is not good news for a good outcome.
Yeah, they're basically guaranteed frozen shoulder after the surgery then.
Right. After the surgery, the patient is immobilized, at least to a certain extent. In order to heal, they're told not to do certain movements. And if they're starting off with such a severely frozen shoulder, they don't have a good rehabilitation. So I do work with people who are going to need surgery also because they have a tear going on at the same time. But I also work with people who have a frozen shoulder for whatever other reason, and I work with those as well.
I see. In your chapter in the book, Clinical Mastery in the Treatment of Pain, and I'll include a link below for the interested listener, you mention a number of modalities such as spray and stretch, the percussion method with a reflex hammer, where you're kind of mildly tractioning the muscle, which I think is a form of myofascial release. A number of other ones. Could you describe to the audience what are the common modalities you use in just a typical frozen shoulder patient that you see?
Well, basically, I do use spray and stretch often on the first visit. Spray and stretch is a modality to increase range of motion by distracting the brain, by using a very cold stimulus that you move across the area. Now, I always treat the neck as well as the shoulder because trigger points in the neck area do affect the shoulder as well. So taking the neck into normal ranges of motion to release the taut bands and trigger points in the neck, and then taking the shoulder through the ranges that can be performed with the spray and stretch. But then for future visits, usually I just use the manual techniques and the percussion technique. And the percussion technique is something that I use because I can't needle the muscle, and I don't just want to dig in really deeply in order to get deep areas to release. And it turns out that percussion can affect several layers deeper than where I'm palpating. And so it's a way to not put the patient into as much pain, but soften and release the fascial tissue, the joint capsule, and the muscles so that the range of motion can be improved more readily.
And I remember you mentioned in your chapter that for certain patients, especially if they're, I'll say, sluggish in their response to what you do, that you may have them undergo some trigger point injection work on subscapularis, serratus anterior, and the pectoralis muscles, I think, are the ones that you mentioned.
That's correct.
So you're not opposed to the injection work. It's just because of licensing, then we're limited in our scope of practice. Is that the main concern? Is that
correct? And essentially, when I first start working with a frozen shoulder, they have so much muscle involvement and fascial involvement and capsular involvement that it helps if I can localize the problem to a degree. And then if things aren't fully releasing, dry needling is effective and injection is effective, either or both, just depending on the preference of the patient and what I think they'll respond best to. So I do refer regularly if patients aren't making rapid progress in their improvement.
And I think you brought up a core concept in myofascial pain, this idea of centralization, where sometimes when you first see a patient, it's this whole region is just lit up and they can't even pinpoint, sorry about the pun, pinpoint where the problem is. And then as we make progress, this pain will tend to centralize, and then the referral will be even more effective because they wouldn't be just pecking around in the dark. They'd be able to know exactly which spots to treat. Is that a good summation?
We say that we don't want to make the patient into a pincushion.
Yeah.
So we try to localize the involvement to the most important areas. And you're correct, the areas that we usually send them for a trigger point release with a needle are exactly the ones that you mentioned.
Mm. Are there certain problems of the shoulder that you have trouble with and that they're a clear case to refer out to possibly surgically? For me personally, I've seen full thickness tears of the supraspinatus are really difficult for me to resolve using trigger points. Do you have trouble with that one? Or are there any others that you would consider to be
theoretically, a full thickness tear usually does not heal on its own, even with all of our help. I have had one patient that did have a clear diagnosis of a full thickness tear, and I was co-treating the patient at the time with a doctor of Oriental medicine who also performed prolotherapy. So in New Mexico, the licensure is such that glucose can be injected into the tendon areas. And in fact, this patient I had expected to be treating just to get his movement improved so that he could have surgery. But when we proceeded with his care, he got back the function of the supraspinatus muscle. So you can do muscle testing to evaluate all of the rotator cuff muscles and see whether any of them are torn. The supraspinatus is the most common muscle to tear because when someone falls hard on the shoulder, it's very quickly elongated and can be ripped. And so that's the commonest rotator cuff muscle to be torn. And in this case, it apparently healed. He did not have another MRI performed because there was no diagnostic need. The orthopedic surgeon decided that since his function had returned, there was no need to do an after test. But he apparently re-knitted that muscle with the prolotherapy performed by the doctor of Oriental medicine to help that tendon.
Oh, fantastic. That's a great story.
Thank you for listening. Watch for Eric's book on advanced Asher acupuncture techniques. Don't miss being notified of its release date and when the latest blogs on useful clinical tips and techniques are posted. Stay informed and up to date by signing up now at our website, asher-acupuncture.com. Now back to the program.
When you mentioned testing the shoulder for rotator cuff tears, you mean things like the empty can test, full can test, resistive exercise, resistive
you
tests?
You can test each of the muscles, the supraspinatus, the infraspinatus, teres minor, etc. You can, subscapularis. There are specific muscle tests for each muscle. So it's a little bit different from the grouped tests that are done with the empty can, etc. But essentially, you can test each muscle separately.
I see. Do you have any advice for, say, acupuncturists that aren't trained as much as chiropractors on radiculopathy? And are there simple assessments that acupuncturists could consider to whether they could rule out cervical involvement in shoulder pain? Like, would some of the compressive tests help, like Jackson's, Sperling's, or just cervical compression? Is that any advice on ruling out cervical involvement in the shoulder?
Well, sure. I mean, the simplest test is simply that if when the patient takes the head and neck toward the side of the pain problem, the pain increases, then it's an indicator that there could well be some nerve root involvement, or at least some facet. The little nerves that are in the cervical facet joints could be involved as well, and they can refer into the shoulder also. So basically, that test can be performed. Compression can be added to it to see if that makes things worse. If the patient gets more pain when they go the opposite way, then it is more likely to be a myofascial problem because you're putting, for example, the scalene on stretch, and it refers into the shoulder, and the levator refers into the shoulder as well. So it's very important to look at the neck musculature that refers into the shoulder as well as the muscles that are in the shoulder itself. And then if there is pain down the arm, that's an indicator if there are any weaknesses of muscles in the arm or the hand. If the patient finds themselves dropping things, those are all indicators that there may well be nerve involvement.
Great. You, I think in the introduction that you sent me when we were emailing, you mentioned you do a CEU courses for acupuncturists. Could you talk about that? Is this where people could learn the different modalities that you use clinically?
Sure, absolutely. The University of New Mexico has had a regular program of continuing medical education, but the hours are also approved for other professions. And they're specifically an interdisciplinary program. And we set them up because you can't really learn the detail of finding hard to find trigger points just by reading a book or watching a video. Mm-hmm. It really helps to have coaching. And we have enough trained people in New Mexico, in the Albuquerque area, or including Taos, that we can have 20 facilitators who will each work with a small group and coach them through finding the trigger points. And the last course that we did at the end of January also included the needling techniques for the trigger points, and it did include introducing those to acupuncturists who want to be doing those techniques. Of course, it's all done within understanding how you initially make a myofascial diagnosis, how you decide which things are important. And I can give you an example here. I had a patient who had a work injury, and she had headaches that came up the back of her head and into her eye, and she had pain inside her scapula, and she had pain and numbness down her right arm, and she had a lot of soreness at the base of the neck. And the physical medicine doctor treating her performed trigger point injections on her upper trapezius. And since this did not relieve her pain, with 2 repetitions of those injections, it was decided that the patient was not a candidate for trigger point injection. Well, it just so happens that none of the patient's pain pattern related to the upper trapezius muscle. So yes, it was a sore spot in the area where she had pain, but it was not totally irrelevant, but not terribly relevant to what was going on. Now, in order to get her, we did need needling techniques. She'd had this problem for 1.5 years when she came to me. I had to include in my treatment plan referral to an acupuncturist that I work with in my treatment team for pain management. We had to call it pain management so that we could do the dry needling of the pectoralis minor that was involved in the compression of the nerves down the arm, the sternocleidomastoid that was involved in the headache pain, the posterior scalene that was involved in sending the pain down into the upper back. So essentially, you have to perform an appropriate diagnostic procedure. And so that's one of the things that we really focus on in the course at University of New Mexico. And we do them about once a year, and they focus on introducing people to the general concepts. And then we're doing in-depth courses now. This time we did the upper body, but we'll do the lower back, I believe, the next time we do them in a year or so. And so we haven't planned that course out yet. But I think it is extremely rewarding for all the members of the healthcare team who are going to be eventually working to help people together to learn in the same environment. So, for example, the massage therapists, when they come to those courses for the first time, they're very nervous because they're going to be in a course with medical doctors. And it turns out that when we break up into the small groups and we're doing the hands-on, the massage therapists are helping the medical doctors learn their way around the body and know where they are. And it's just fabulous because the medical doctors get to recognize the expertise of the manual therapists and of the acupuncturists and the other folks that they're in the groups with. And then they are much likelier to refer to those folks in the future and include them in their treatment group.
That sounds like a great program. Do you guys have a website devoted to that program?
There's the Continuing Medical Education website, University of New Mexico.
And I'll make sure to include a link below for that.
And then the next time I will be teaching and we'll be doing an interdisciplinary program is actually, we're doing an introductory program in September.
Okay, and the audio quality is getting a little choppy now and then. So, Dr. Ferguson, I thank you so much for taking the time to share your wealth of knowledge with us. And I hope you'll consider talking to me again when I do a series on the hip pain in the future.
Oh, that would be great. That's one of my favorite areas, as you know. So
yeah.
I would love to talk about hip pain.
Thanks again, Dr. Ferguson.
We hope you've enjoyed this episode of the ASHO Acupuncture Podcast. We'd like to hear from you. If you have a question, topic idea, guest idea, or a particular technique you'd like to hear discussed on the show, contact us at our website, asho-acupuncture.com. That's ashi-acupuncture.com.